So these are parts of miscellaneous topics that I wanted to continue. Okay. So breaking bad news and conflict in ICU, coming to the introduction, communication is one of the most important and crucial aspects of patient care because patients are often critically ill, and because of which families are usually anxious, and majorly when we ask them to do take decisions, it will be under stress. So this is a very tight scenario, correct? So communication in such scenarios become very important. So what is the importance of communication in ICU? It should ensure clarity in patient care goals among healthcare providers, patients when possible, and to the family. All three of the groups which are involved should have an idea of what is happening. Next, we should always build the trust because the two parties are new. Okay, we should have trust on the family, and the family should have trust on the treating physician, wherein we can reduce anxiety and have ease of care for the patient. Okay, that is the primary focus. Most of the times, shared decision making is what is necessary, especially when we are thinking about end of life decision. If we do all of this, that is, if we ensure clarity of thought, build trust, reduce anxiety, involve family in shared decision making, it usually reduces conflicts and misunderstanding, and better healthcare delivery can be given. So what are the key principles? So now we have understood that. So the key principles are clarity of thought. Whenever you're talking to the family, use simple language, avoid jargon-free words. It should be an empathetic way, okay? Acknowledge the emotions of the opposite party and show compassion. It should be transparent. Share good and bad updates honestly. All team members should provide uniform information. There should not be, disparity between communication. So consistent information should be there. You are telling one thing, your surgeon tells another thing. Okay, that should not happen. So usually best way to do it is together. If not possible, whenever it is happening, it should be coherent. Always have active listening. Listen to what the concerns of the family are, however trivial they are. Address them so that it does not build into a mountain of pressure later on. Okay. So what are the modes of communication? Again, when we're talking of modes of communication, firstly, we need to know whom are we communicating with, whether it is the patient, family, within the healthcare team. All of this is a part of communication. And how do we do this? It can be verbal, non-verbal, or with some charts, etc. Right? So what are the types of communication in ICU? Firstly, we have verbal, that can be direct conversation, formal discussion, telephonic conversation, etc. Non-verbal, usually it looks at body language, facial expressions, eye contact, okay, touch, proxemics, posturing, and gestures. Written communication majorly looks at medical notes, charts, consent forms, summaries, medication orders, care plans, etc. Communication tools in the era of AI, we are looking at electronic health records, telemedicine, video consultations, etc. Interprofessional communications, usually when we have it, is major in handover protocols like the S bar or IS bar. Okay, so that we have a structured format wherein we do not miss the key aspects of handing over, which is very much important to have a continued process of care. Okay, so this is another type of communication. And lastly, and most importantly, family communication, especially where it comes as when we're giving bad news. Okay, talking about prognosis, treatment options, informed consent, end of life care. Okay, all of this we need to look at that. Okay, so what are the principles of communication? We need to look at how do we prepare, how do we assess, how do we deliver, how do we validate, and how to follow. Okay, so in preparation, you have to do communication in a private, quiet, closed environment. It should have minimal interruptions. Better to have a team. Okay, usually a senior staff, nurse, etc. can also accompany you. Okay, along with appropriate seating, comfortable seating, and then introduce yourself. That is very important before you start communication. Okay, so you don't know who the opposite person is, so you start by that, break the ice. Okay, so introduce yourself first. Make sure that the opposite patient person is also comfortable, and then start your communication. Next comes assessment. In assessment, what do we first do? Firstly, we acknowledge the person's emotional issues if there are any. After that, you need to identify who the proxy is. After identification, we need to understand what is the understanding capability of the person. Okay, so you need to make sure that the opposite person understands what the plan of care for that particular patient is. Okay, so for that, you need to understand the level of understanding of the relative or the patient. After having understood all of this, we need to deliver it. What do we deliver? A clear, compassionate communication about the current health status. What is the prognosis? If at all there is hope provided, otherwise, please lay down the facts based on evidence. Okay, so this is what we look in effective communication. After having said that, always validate. Okay, listen to the concerns of the person. Okay, give them emotional support. Check for comprehension. After you have given your delivery, after you have told the prognosis plan of care, ask them, do you want to ask anything else? Are you clear about it? Is there anything else you want to know? Okay, so this is about validation. Finally, you will have follow-up. Follow-up is documentation of the above said things, wherein you document a plan of care, you will document prognosis which has been explained, you will document what are the risks which have been explained. Okay, all of this is something that we do in communication and follow-up. So whenever we have communication which is looked into, it can be in two settings, right? One is an emergency situation, one is a planned discussion. In emergent discussion, always time is of the essence. We don't have much time. So you will come, introduce yourself, give a clear, concise message, and tell them that you will come back and talk to them in detail later on. The only thing you will want to check at that time is comprehension of whatever the message you wanted to give. Say, for example, you have a patient with cardiac arrest. We'll just go identify the person who's there outside, tell them that you have an emergency news that you have to break in. You will introduce yourself, tell them what the news is, tell them that you're doing everything possible to revive the patient, and you will come back and give a brief detail after having said, done what is necessary. So that is what we do in an emergent situation. What do we do in a planned discussion? We have all the things that I mentioned earlier, wherein you prepare, okay, and you make sure you assess the person, deliver, you validate, and then follow up. Okay, so that is what we do in a planned discussion. In an emergent discussion, we might usually skip few of the non-essential things. Okay, so whenever we're talking about the things that I mentioned earlier, always introduce your team, explore the current understanding, identify what is the goal that you want to reach. After that, give all of this, validate and conclude and document. Okay, these are the effective steps of communication. Okay, so coming to breaking bad news, okay, what do we do? Usually the goals of communication during end of life care becomes a really taxing one. Okay, so establishing consensus about the disease processes among the care givers is very important. So you should not tell that there is hope and someone else comes and tells no, there is futility. Okay, so that should not happen. There should not be disparity. There should be clarity. Okay, so that has to be established. Once you have done that, then go out and then give bad news, whichever is there. Okay, so it should be accurate, it should be appropriate. Okay, nothing less or nothing more. Okay, along with this, look at what is the patient's family's concerns or patient's concerns, and you have to elicit them and resolve the concerns at the same time, and do not push it over. Okay, preliminary approach whenever you're giving breaking bad news. uh, how do we do it? You can remember the mnemonic value stands for value the statements by the family members, acknowledge the family members emotions, listen to the family members, understand what the patient or the family member wants, okay, and what decision making is awaited based on their understanding, and then finally conclude by eliciting questions. Okay, so that you can, one, understand that their comprehension is good, two, you have given them an opportunity to close the communication. Okay, so this is one useful mnemonic: value. Okay, statements, acknowledgement, listening, understanding, and eliciting. Okay, coming to non-verbal communication, the tool we all know is solar. Okay, so solar stands for face the patient or the family squarely at eye level, indicate that you are interested in involvement. Okay, don't look down, always maintain eye contact, adopt an open body posture, don't crouch and don't look very shabby. Okay, you should be looking like you are interested to know what the opposite person wants to say. Lean forward to the patient or the family and listen to them. Always use eye contact to show that you're paying careful attention. Okay, and maintain a relaxed posture. Don't look like you're in a hurry to go somewhere. Okay, so solar stands for squarely at eye level, open body posture, lean towards the patient. Okay, and maintaining of eye contact and relaxed body posture. This is solar. Family-centric approach, again, the useful mnemonic is spikes. Okay, I told you earlier, right? When you're communicating, I use those. Okay, remember it in setting, perception, invitation, knowledge, emotion, and summary or strategy. Okay, it's similar to what we did earlier. Okay, setting is the quiet environment, comfortable seating, introduction of the team. Okay, timing appropriateness. You have to ask the family also so that all of them are not having any issues. Perception, again, you should know what is the comprehensive capability of the opposite party. Invitation is to ask them, would you like to know about anything? Would you like to discuss about the test results, etc.? Okay, and knowledge is after you've given all the details to them, understand, ask them to tell you what else they want to know and what have they understood. So finally, if at all it's bad news, obviously they will break down. So you have to acknowledge the emotion, okay, and be empathetic towards them, okay, and in the end summarize and document whatever has undergone. Okay, that is most important, though. That is spikes protocol. Okay, coming to the last part of the miscellaneous topic, that is conflict in ICU. Okay, conflict is a complex behavior where one party perceives that it is the interest uh, conflict is a complex behavior where one party perceives that its interests are being opposed or negatively affected by another party. Okay, usually it is two meme types. Okay, so dysfunctional conflict usually hinders individual or organizational performance. So one feels superior over the other, etc. So this is very common in the medical background. Okay, so these issues are things that we face on a daily basis. So how do we deal with conflicts? Conflicts can be of different types. What are they? Firstly, you need to know there are professional conflicts, that is between the healthcare team members, disagreements on treatment, hierarchical tensions, and communication breakdowns. Second type of conflict is between the patient and the family. Sometimes patient wants something, the family wants something else. So usually there will be a difficulty in coming to consensus when this is present, okay, especially in end of life care choices, etc. Finally, ethical conflicts are one things which are really difficult to handle, especially when it comes to treatment futility, autonomy of the patients, resource limitations, and cultural differences. Okay, so these are the conflicts which is by and large present. Okay, so there are various factors that can cause conflicts. Okay, so this is what I have categorized and put it in the previous slide. So you can remember it as professional conflicts, patient family conflicts, family physician conflicts, and ethical conflicts. Okay. What is conflict resolution? Okay, we'll look at a comprehensive approach. Majorly, two things that have to be looked into. Okay, first major problem with conflict is poor communication. Okay, we have to actively listen to the opposite party, have an empathetic approach. We should clearly communicate, maintain neutral language, and respect throughout the conversation. So, part B of comprehensive approach is emotional management. Recognize the emotions, especially when it is between physician and the family or a patient. Okay, so we will be thinking only towards medical management. The family will be thinking of the other aspects as well. So we have to uphold that and respect that. Okay, so control personal reactions, validate the feelings, and remain professional throughout. Okay, so there is no best way forward in conflict resolution, but one good thing is interest-based negotiation or principled negotiation. Okay, so what is principled negotiation or interest-based negotiation? It is a collaborative response to conflict. Okay, so here it is like a win-win situation wherein we come to a middle ground. Okay, usually it cannot be so, but at least both the parties will go back thinking that they have won. Okay, this can be achieved, okay, based on proper understanding. So how can we do this and what are the advantages and disadvantages? So interest-based negotiation is advantageous by breaking the typical conflict cycle. Okay, so arguments can be broken down. We will be giving them time to have a structured thinking and process. Interests of both the parties will be taken into consideration. Options will be analyzed and then implemented. Okay, it helps us separate the important from the unimportant and helps us negotiate constructively. The only disadvantage is probably there's still going to be some amount of suspicion and mistrust at the end of it. Okay, so how do we do this? First, we need to explore shared interests. So all of us want the good for the patient itself, right? So we need to reach the middle ground. Okay, so each party analyzes what is the middle ground. Okay, and then we have to come to an understanding what is the best way forward. Secondly, we have to look at each other as an ally and not an enemy. We have to look at risk versus benefit, agreement versus disagreements, and then come to a middle ground there also. Okay, so usually there should not be any conflict. Okay, so enlightened interest should be achieved after brainstorming. Okay, so it should be that this patient, or the person that we are trying to treat should have optimal outcomes on middle grounds. Okay, so that both the parties do not have any issues when implementation. Okay, this thing comes into picture when we are talking about end of life care mostly. Okay, so once we are able to do all the brainstorming, we have chalked out a plan of action. We have come to an understanding that both the interests are aligned, and then there is no negotiation which is hampering each other. Okay, so mutual consensus can be agreed upon. So after this, we come to implementation of whatever decision that has been done. So what are the take-home points in breaking bad news in the ICU? Always prepare well, gather the facts, be consistent, assess the understanding of the opposite party, be clear and honest. Don't give any false hopes when there are none. Acknowledge the emotions, offer support to the family. Use frameworks and mnemonics like spikes, solar value, etc. Okay, so always recognize futility of care. If at all there is a conflict which comes in, sit, discuss what is the pros and cons of each thing, and then find the middle ground and implement them. Always build trust because you're dealing with people on a daily basis who are new to you. Okay, so the only way that we can go about and get best treatment is by building trust. Okay, concessions can be done wisely when we feel that patient-centric values are not going to be compromised. Okay, and whatever we do in all of this in end-of-life care, communication, etc., it should be documented always. Okay, and this is because it always one we have a backup for any legal issues, and it always maintains transparency between both the parties. Okay, so we can look at the same end-of-life plan which I've mentioned earlier as well to look in about how to deal with breaking bad news. Okay, thank you. If there are any questions, I'll be happy to answer in the WhatsApp group. Okay, since this is a recorded session. I'm sorry because I had some technical glitches which I'm still trying to solve. Okay, thank you.